Good afternoon. Today is March 3rd, 2023. Welcome to Bariatric Friday. My name is Kemal Erkan. I'm the chairman of American Surgery Center and United Medical ACO. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. It's great to be back again on another session of Bariatric Friday.
It's always good to have you. So we are going to discuss, our topic today is the day of the surgery. So because of the nature of the bariatric surgery, the preparation is not something that's only for 1 week or 2 weeks. From the consult to the surgery, it may be several months, anywhere from 2.5, 3 months to 6, 7 months, based on the insurances. So this prep is a lot of work for all our patients. But I think when it comes to the day of the surgery and how we are preparing for that day, and it lasts maybe 2 weeks of prior to surgery, and just so that we have a good understanding of how we are preparing them and what to expect on the day of, if we can just discuss those together.
Absolutely. That's very important, Kemal. As you say, the bariatric surgery is different from other forms of surgery that patients may be familiar with, because precisely there is a fairly extensive preparation period that sometimes can be as long as 6 months based on requirements from insurance plans. It is important, as we say always, to understand that it is a very serious medical treatment. And we treat a very serious medical problem, which is morbid obesity. From our point of view, as we've said over and over in our Bariatric Friday sessions, Kemal, obesity is not only a mere matter of convenience problems or appearance problem, it's essentially a medical problem. And the main way to explain why it is a medical problem is because as soon as we, cross that threshold of weight that is categorized as morbid obesity, then we see the appearance of a number of very serious medical conditions that really are caused by obesity itself. And this could be serious problems like type 2 diabetes, like high blood pressure or sleep apnea, which by themselves are chronic and potentially life-threatening conditions as well. And essentially, bariatric surgery by far currently is the most effective treatment option we have for morbid obesity. And we define morbid obesity, as we've said, as a weight that is at least 100 pounds over the person's ideal body weight. And sometimes that's also expressed in body mass index. And we say a body mass index greater than 40 defines morbid obesity, although sometimes even a body mass index as low as 35 can make a person a candidate for surgery if they've already developed medical conditions associated with obesity, like, as I say, type 2 diabetes, high blood pressure, or sleep apnea. So first of all, why is the preparation so extensive? Well, its preparation is extensive, Kemal, precisely because after the surgery, there are essential changes that the person has to be prepared for, right? For instance, the surgeries that we undertake all involve reduction of the size of the stomach to some extent, right? Whether this is the sleeve gastrectomy or the gastric bypass, the stomach is smaller. So immediately the person will notice that they will not be able to eat as much food as they were able to eat before. Just the capacity is not there, even if they wanted to. Although, interestingly, even that appetite for a bigger meal actually disappears for a number of reasons after bariatric surgery, which is why bariatric surgery is so successful. So how do you really prepare a person for that? Well, you have to educate them. You have to expose them to nutritional classes. There have to be psychology evaluations, and then there are other medical preparations as well. So typically, before we approach the day of surgery, our patients will have been with us for a long period of time, and they will have been really in our case conferences for a number of weeks, where our bariatric coordinators will be discussing their case day in and day out. And so finally the day arrives, right? And the day of surgery, it is a day of apprehension as well as excitement for patients, right? And this combination of emotions is actually strange for patients, right? Because they don't understand it. On the one hand, they are excited because they will be doing something to get rid of this weight. but at the same time, also they are undergoing surgeries, which is a source of apprehension. But actually, it is expected. It's very normal to have this combination of emotions, excitement and apprehension, right? And one of the biggest things that we have at our surgery center, Kemal, is because we do this day in and day out, is to really reduce that apprehension with which the patients come to our center first, right? They are greeted by people who take care of morbid obesity day in and day out, starting from the reception area all the way to the nurses in the recovery area, right? So they are they go to the reception area, they get registered, and they go to the pre-op area where they will start the preparation, with intravenous medications to be given for them. Then they will have interviews with the nurses as well as the anesthesiologist. And of course, they will see their surgeon as well, where they can discuss any issues or any questions that they may have, even at that late stage.
Now, I just want to kind of put it in like a real life perspective a little bit. So. Mm-hmm. Because we give a lot of overall information. So again, you and I, we go through case conferences every day. We prepare our patients, our screening process or preparation process, whichever we want to call. During that time, we get to know them a lot. Like we learn about them, we know about them. And like, just to give you an example, so any patient on an average, so they need to get a blood work. So after the initial consult, right? So then assuming that blood work doesn't require any follow-up, then they have to get a cardiology clearance in most cases. Mm-hmm. That requires about two encounters. One is the visit, one is the echo test that they do. They need to get a home sleep study in most cases. Then based on that, they may need to get a CPAP. Then they need to get 3 to 6 nutrition classes depending on the insurance requirements.
Yeah.
They need to get site clearance.
Yeah.
They need to get medical clearance from our bariatrician.
Yeah.
And finally, they need to get an EGD. Not finally, but one of the, like, I'm not going in any order. But EGD is another one. And based on the EGD, we may have some follow-ups. So there are several different steps that a patient needs to take. But then I see someone who completed all these. Like the reason I was just giving you this overwhelming list, kind of like it's really not overwhelming because we actually have our care coordinators who are helping the patients. But I see everything, and then they got to the point to the surgical clearance. And just put it in a little bit more perspective. So one of the Medicaid patients who did 6 consecutive month nutrition classes, and all these other clearances, and the prep from the consult to the time of the expected surgery date is about 8 months. And last minute, she, in this case, she doesn't want to do it. So that's why I think like understanding what's going to happen at the day of surgery and what is required, the last step of the surgery of 2 weeks diet. I want to kind of like explain that process. So like, why do we do these 2 weeks diet prior to surgery? We have mentioned in other sessions, but just so that this is 2023. So then it's the 51st date, right? So we forgot everything that we learned in 2022. So we start fresh. So why do we have to, why do I have, like, I'm already having surgery to lose weight, but you want me to be on a diet that I can really just not tolerate the last 2 weeks and my BMI is 47. Why are you doing that to me?
Great. I mean, that's a fair question. That question comes up all the time. So first of all, there is no rite of passage here. We're not testing anyone to see whether they can go through this. That would be far from our mind because they've been tested already all their life with this terrible, problem of the weight and the trials that they've gone through with different diets, with different methods. So there's no testing at all. That's not the idea. However, there are some crucially important parts of the preparation for a safe bariatric surgery that we as bariatric surgeons have learned through years of experience. And one of them is that when patients present for surgery, and they are overweight and they are morbidly obese, the size of the liver is large, right? The liver is the solid organ we have in our upper abdomen, and the liver in its position happens to actually cover the stomach, and the stomach is the target for our surgery, right? Which means that we have to be able to push and protect the liver away from the stomach when we're doing the surgery, right? Now, if the liver is not only large, but it is very dense, very difficult to manipulate, that can actually make the surgery very challenging, if not dangerous, right? Because in an attempt to push away the liver that is very dense, the liver itself could be injured, and that can lead to very serious bleeding, okay? And sometimes the liver could be so large that repositioning it away from the stomach may just not be physically possible, and the surgery may have to be aborted, right? And prior to us utilizing this diet, I have personally encountered such a situation, Kemal. I think we've started doing this diet now about maybe 13, 14 years ago, Kemal. And since then, I haven't encountered this situation. But before, there were situations where we got into the abdomen and the edge of the liver was so low in the abdomen that there was no way that we could physically move it to do the surgery. So we have to put patients through this special diet that helps us to really shrink the liver. Not only the liver becomes smaller, but it becomes much softer. So when we are trying to move it away from the area of surgery, we can move it safely without having any danger of injuring the liver. So this diet happens to work very well. And I know patients ask for different alternatives and stuff, but this happens to be the one that really works very well in terms of reducing what we call visceral fat, the fat that we have inside, the fat that really is so densely inside the liver.
I want to go back to the image of the liver and the stomach, so that and then I know now our patients are more engaged with our sessions, with our YouTube events, with the Bariatric Friday. So, because we get this question all the time, so we are saying that the 2 weeks diet, this is a healthy liver here, right?
Yeah.
And then this is a healthy stomach. In our case, it's a little bit different. So, but this organ here is almost covering up the top part of the stomach.
Yes, in fact, I mean, this image is obviously a diagrammatic, representation, Kemal, but in reality, the liver actually covers the upper portion of the stomach completely, right? So, but when we're doing surgery, we want this picture. We want the liver to be high up and the stomach completely exposed, right?
That's why I was saying that this is like a healthier.
Yes, absolutely, absolutely. This is retracted. The liver has been repositioned so that the stomach could be visualized very clearly.
The goal is not to get the patient just lose weight for bariatric surgery. It's to make the liver smaller.
Absolutely, absolutely, yes. I mean, granted, Kemal, it's also important to understand that there are certain patients who present at very high levels of weight that we want them to try to lose weight before the surgery, knowing that very often losing weight for a short period of time is actually not difficult for them. They've done it time and time again. It's keeping that weight off, which is difficult. So in preparation for the surgery, somebody who presents really at very high ends of the weight, we help them. We help them to try to come down on the weight. Clearly, the preparation we do through the education with the nutritionists help, but we do other important interventions that lead to short-term weight loss that help us greatly as well. So for the average patient in our program, as you know, has a body mass index between 45 and 50, right? For that range, we don't need necessarily weight loss as such. We just need a specific diet, as we say, to shrink the liver, right? But there are patients who present with a body mass index of 65, 70, where we think, some weight loss actually may help the overall performance of the surgery, and we actively help them to do that. But this does not apply to the vast majority of patients.
Absolutely. And now, depending on the level of the BMI, we may ask them to do 3 weeks, because if someone's BMI is like 63 versus if someone's BMI is 42, that's going to change the decision, because we want this to be very low risk to protect the patient and make this more pleasant experience. So now I'm able to get through the 2 weeks and I'm at the center. I know that patients are getting a call before the surgery from the surgery center.
Yes.
Time of the surgery and what they can and what they cannot bring and what we need. But in terms of expectation of who would perform the surgery is 99%. It's going to be the person who had the consult.
Yes, absolutely. Absolutely. That would be the surgeon that saw them in consultation will be performing the surgery. Yeah.
Absolutely. Now I'm in the surgery center and I came there early in the morning. So what am I expecting for that day?
So obviously the surgery center not only will have called them ahead of time, but will have given them instructions as well. One of the important instructions, for instance, is to have nothing to eat or drink after midnight, the night before the surgery. But also the surgery center will ask them to take some medications, right? The medications that they may be on. If they're taking high blood pressure medications, for instance, we'll encourage them to take this medication with a sip of water. But as part of our preparation to have minimum discomfort from the surgery, we actually proactively ask our patients to take some type of pain medication even before they come to our center, right? That primes them to have less discomfort as they wake up from surgery. For instance, they will ask them to take 1,000 milligrams of Tylenol at home before they come to the center with a sip of water. And once they've come to the center and they've registered and they've come to the pre-op area, we will give them additional medication that are medications that will prepare them to have less discomfort after the surgery. So as you can see, there has been a complete shift in the way we deal with pain, right? Pain in the past, when I was trained, was something that patients complain about, and then you give them pain medication. So by the time you get to give them pain medication, the patient has been suffering from a lot of pain, essentially. But reducing the amount of pain that comes from surgery has been really a very, very important development in surgery, right? And surgeons have been very good now at paying attention to this very, very important fact. And surgery centers like ours have excelled in really adapting this, because there would be no way of really performing outpatient surgery if you were not able to control the discomfort that patients have after surgery, right? But how do we control the pain? Well, not only by giving pain medication when you feel the pain, but proactively preparing the body to have less pain. And we have medications that enable us to do that. And those medications are given even before the surgery is performed. Absolutely. There are also other things that we have to do. Again, this is all about prevention. It's about preparation. And one of the things we want to prevent, Kemal, is blood clots. Blood clots can happen with any type of surgery, but our patients, because they are suffering from obesity, they're actually at higher risk for blood clots as well. And so it is very important for us to focus on prevention of this. And there are medications that we give before surgery to do that, to reduce the risk of blood clots. And one of those medications,
part of our preparation process being
absolutely.
So good, because we want to make sure that we are able to identify these problems ahead of time.
Yes.
So part of the blood work that we do, and the reason that we have cardiology in many cases, this is helping us to eliminate these problems, because we don't want to have this issue at the surgery or right after the surgery. As you said, that our patients are high risk because of the morbid obesity. Now, in the surgery center, while we are there, the pre-op is about, I believe it's about 90 minutes, if I'm not mistaken. And then the surgery can be about like 60 to 90 minutes based on.
Absolutely. I would say it's anywhere between an hour and an hour and a half, sometimes an hour and 15 minutes, but no longer than that. And that applies to all procedures, whether it's gastric sleeve or gastric bypass. The actual surgery, really, probably on average, the gastric sleeve is about an hour actually in our center.
And as soon as the patient is in the recovery, we call it PACU unit. Then you mentioned the medications, the pain medications, and one of the things that we adopted, and I believe it's not very common in other facilities.
Well, no, it's being adopted now more and more, but we've been doing this for a number of years now in our center, where we have this, what is called enhanced recovery from anesthesia, which means that we want our patients to be able to be up and about very soon after the anesthesia wears off. And one of the things you have to be able to do that for that is you have to reduce the level of discomfort. You have to reduce other side effects of anesthesia, like nausea, for instance, right? And we do this, again, proactively. Well, one of the ways in which we reduce discomfort after the surgery, Kemal, is by strategically placing numbing medicine in the abdomen when the patient is already asleep, so that when they wake up, they don't feel the discomfort from the incisions. And as I told you many times, you know, early in my career, one of the dreadful things for me was to see patients waking up from anesthesia with a big frown on their forehead, suggesting that they're really uncomfortable, right? And we used to say, well, that's part of surgery. Well, actually, by doing this specific intervention with the numbing medicine, actually, you can eliminate that discomfort from the incision. So now when patients wake up from anesthesia, I see them waking up smiling, essentially, because of that. We're able to control that discomfort. And then similarly, because we are not utilizing strong pain medications like the narcotic, the opioids, for instance, we're able to reduce the side effects of opioids. You know, one of the side effects of narcotic pain medications, Kemal, is nausea and vomiting. Well, by eliminating those medications, you eliminate the the risk of nausea and vomiting as well. So patients will really be able to recover quickly from anesthesia, which means they will be able to be up and walking very early. And that's one of the goals of our recovery area for the nurses, is they have, benchmarks. After a certain period of time, they have to get the patient up and walking. And when you're at the surgery center, very often you will see patients walking around. These are patients who had surgery an hour and a half or 2 hours before, and they are already walking around. And that's tremendous, because not only you are able to decrease complications by having the patient walking early, right? Like blood clots, pneumonia, and others. But in my view, when you're able to get patients to walk, Kemal, you actually transform the thinking of the brain itself. It doesn't think in terms of a sick person, right? Like if you're in bed and lying horizontally all day long, it's very easy to assume the role of the sick person who needs to be taken care of, who cannot do anything, right? But if you're up and about and vertical, you're assuming more of a person who's recovering, who is not sick anymore. And that's the kind of mindset that we want our patients to have, because that will be almost like a roller coaster, because they feel better. So therefore they will be walking. And if they're walking, they will recover faster. So it's almost like a cycle of positive. Right? Yeah, absolutely. That goes ahead. And this is reflected also in how long our patients take pain medication after surgery. Very often they will tell you, well, I took it for a day, maybe 2 days, and now we're off after that. And we're talking about major surgery, right, Kemal? But this is what you have to be able to prepare patients for, to provide really safe and high quality bariatric surgery nowadays.
But if you remember, this is one thing that I learned from you early on, when this is kind of like my next thing to remind our patients, you don't stay there overnight. So the average discharge from the PACU, from the recovery, is average range is about 6 to 8 hours.
Yeah.
So we had in the last 12 months, a little over 400 cases. Only 2 patients had to stay, and they have some special issues, not clinical, so we had to keep them. So they will go home. The idea is the whole mentality of like, am I sick or am I recovering, and where do I get recovered the fastest? Because there was this misperception of, well, if I'm in the hospital, I'm safer. Well, that's not correct. Hospitals are not safe from that point if you don't have to be there. Absolutely.
Yes, I mean, of course, as we always say, there are certain patients who definitely need to have their surgery done in a hospital setting because they require specific treatments for other conditions that they may have. This may be severe heart disease, kidney disease, lung disease, where we will need them to stay in hospital longer. We will need the input of specialists and so forth. But for the vast majority of our patients having elective bariatric surgery, it's an outpatient procedure for that purpose. Of course, as you mentioned, if patients need to stay overnight, we have the capability of offering that, but the vast majority of patients don't require that. So in terms of what patients are going to be expecting, of course, even though this is outpatient surgery, they will be with us for about 6 to 8 hours after their surgery. So as far as the patient is concerned, it's an all-day affair, essentially, from the time in which they arrive to the surgery center, they're in the recovery area, and then about 6 to 8 hours afterwards.
So the key is like early mobilization.
Yes.
Is preparing, and I think the hydration, do we want to actually kind of address the hydration issue? Like, if anything that I do prior to surgery in terms of better hydration, is there a way to do that, or is it something that's going to hit and miss?
Sure. So first of all, education is important. It's important for our patients to understand that hydration is very important. Now, why do we emphasize on that? Well, because after the surgery, because their stomach is very small and it also tends to be stiff very early, they cannot drink a lot of water at once, right? So the strategy that they have to adopt is to drink small amounts but frequently. Right. So the way I explain this to patients, Kemal, is I tell them there are 2 ways of filling a bucket with water, right? You can put the bucket under the tap water, turn the tap on and the water will just fill the bucket, right? But another way of doing it would be to keep the bucket there and let the water drip from the tap, right? If you let it drip continuously, eventually that bucket will fill up, right? And that is important for our patients to understand that there are ways for doing that, but they have to proactively take little sips continuously. So if they are not talking, if they are not asleep, they are sipping water, which means they must have some water with them at all times. Now, what is another reason for why patients require more fluid after the surgery? Well, not only their stomach is small, as I said, but they're also not eating the way they were eating before, right? And when you and I are eating normally right now, Kemal, a lot of the food that we eat has a lot of water already. In fact, most foods that we consume will have 60, 75, even 80% water in them. So when we're eating, we're actually hydrating ourselves. Now, when you've cut your eating to a much smaller percentage now, you've also cut your hydration to a much smaller percentage than before, right? Your body still needs that level of hydration that you needed before, which means that to make up for that, you have to develop these strategies, okay? What do we do as a center and as surgeons to help our patients to achieve that? Well, we help them by avoiding things like nausea and vomiting, for instance, and that's, again, part of the preparation, right? We avoid medications that cause nausea. Many of our patients will tell us, oh, I'm in this phase group, of bariatric surgery patients from all over the place, and all patients are complaining about nausea and vomiting. And then I keep telling them, I've had my surgery at the American Surgery Center and I don't have any nausea and vomiting. Is there something wrong with me? And I keep telling our patients, no, there's nothing wrong with you. It's just the way we design the preparation for our surgery minimizes nausea and vomiting. And because of that, our patients now, they don't struggle as much with hydration. Clearly, some patients can still struggle with that, and we want them to reach out to us. And there have been situations in which actually, Kemal, the surgery center has brought patients back to the surgery center to give them IV fluids to just get them through a time in which they've had a hard time getting hydrated. But as you correctly say, hydration is very important. And what we do at the day of surgery to prepare them will help them out, afterwards as well.
Sure.
The other things, obviously, we talk to patients is how do we know, that I am not hydrated? And we, tell patients about the fact that they may be thirsty, right? They will have to have fluid all the time. But also another thing they can do is they check the color of their urine, right? Whenever we are dehydrated, our urine tends to be much more concentrated and darker in color. Whenever we're well hydrated, our urine tends to look more like water. And we want the urine to look like more water. So if they feel that it's getting concentrated, it's time for them to drink more water.
So now, once we go home, before we go home, we need to make sure that there is a family member or a friend who's signed up in the morning who's going to pick us up, so that the person should be picking up the patient, so they won't be able to leave the surgery center by themselves.
Absolutely.
Some patients, they do feel good, and they think that they can do it on their own, but that's not.
It's a big no-no.
That's not possible.
Yeah, it's not possible, obviously, because anesthesia can still linger, and it's safer for them to go with somebody.
And once I go home, what's that going to be like?
So we expect patients to be totally independent once they get home, independent in taking care of themselves, right? So getting up and about, going to their bed, getting off from their bed, going into the bathroom, getting something to drink, preparing themselves something to drink. This should be things that they can do independently. Obviously, they're not ready to drive immediately, so driving will have to wait a few days, which means that before surgery, they will have to have preparations so that there is nothing for them that they would need, whether it's through family support or others, that they will not be able to drive, but they are actually totally independent when they're at home. They ask me whether they are able to go upstairs, for instance, if their bedroom is upstairs, and my answer is absolutely. You may have to go more slowly than you did before, but you can still go upstairs. It's not a problem. Clearly, there are limitations to certain physical activities. For instance, we asked patients not to lift weights, for about 4 weeks after the surgery, and their limits is going to be 15 to 20 pounds. But this doesn't preclude other types of exercise, like walking, for instance. Walking is the foundation of all exercise, and we want our patients to walk. So if they are going to be in bed, it will have to be just because they're tired or they are sleeping. Otherwise, we want them to be up and walking frequently, every half an hour, every hour when they are at home. So walking, and then drinking fluids. And fluids are two very important things that they have to do when they're at home. The other issue, obviously very important, is that we are one phone call away, right? If they have any questions, if they have any concerns, we want them to reach out to us. Even if they feel that that question is not necessary, even if they have doubts as to whether they need to call us or not, we want them to call us still. Importantly, of course, if they have unusual symptoms like too much pain, vomiting, shortness of breath, chest pain, any of those things, obviously that automatically has to trigger a call. But obviously, as they are progressing, if they feel that they are going backwards as well, like if we want every day to feel better than the previous day, but if they start feeling that they are worse than the previous day, then we want them to call us as well to let us know what the issue is.
At the time of discharge, they have a folder, discharge instructions, and one of them, if our patients already didn't sign up for, but there is a QR code now where there's a link for our support group, which we are running that once a month, first Tuesday of each month. And then we also have a Facebook support group where we can interact with each other. And then the next time, if they don't have any complications, they can see us in the next 2 weeks, which there will be a scheduled post-op visit. And what we have seen is, again, like you remember that patient that you sent me, the BMI graph?
Yes.
So was it 100 pounds?
Yeah, it was close to 100 pounds. Yeah.
So we have seen those. So all these difficulties, challenges that we have, because at the end of it, we are going to be able to see good results. And that's why we are taking all these steps to help the patients. And then also patients are taking, I was going to talk to you last week, and I mentioned this in our other session a little bit. Getting ready for the surgery is very challenging. Mm-hmm. So there was a patient that we had to reschedule twice. Mm-hmm. And the third time, she came up on the case conference, and I said to our team, I'm like, look, we have to find out why it's being rescheduled third time. Is it like some emergency? Is it this? Or because it's a major event, so everyone is making preparation months before. So if they need to take time off, they need like coverage. And talking to her was eye-opening, because sometimes we forget how real these issues are and then how it can happen. And she said, look, I mean, this 2 weeks diet is so hard for me. I'm like, okay, so that's why you are actually rescheduling. Unless we do something, we change our course of action, you are not going to have any help from us. So then you can go through this. She talked about how things were difficult in her household because with other people not supporting her decision, her being bullied in high school. So, and there's a lot of social issues there, and you can see, and she said, this is something that I really need to do. And when we made something different there, so we changed a little bit, we changed our approach a little bit and added a couple checkpoints. And her in her voice, the appreciation that I can feel, it was extremely good. And then I know that she's on the schedule now, and then I'm actually checking every other day to see if there's any activity. She's going to have 2 check-ins with our nutritionist. I mean, it's one of the really advantage of what we have with our program, because if there are some changes that needs to be made, that's going to help the patient to go through those times. We are able to do more hand-holding during that process and change our approach a little bit to better help them. I think that's really important for our patients. So tell us, what you are struggling the most. So if we can do anything a little bit more, then we are willing to do that, and we are willing to at least listen and understand. So, Dr. Irgau, thank you so much. So we covered a good part of the day of surgery. Obviously, everything is being communicated from our surgery center, from our care coordination team, and with our surgeons, and before and after. So make sure you follow the instructions.
Absolutely.
Have the written instructions available all the time. So these are not, this is a major decision, and we want to make sure that everyone has a pleasant experience with this. So, well, until next week, please stay safe.